Every video about lowering blood pressure naturally sends you to the same list: garlic, beets, onion. You've seen the title. Maybe you've tried the recipe, but here's what almost no version of this video tells you. One of the most popular techniques in the onion category has no scientific basis at all, and the part that does work, the part backed by actual randomized controlled trial data, almost nobody explains why it matters specifically for a kidney that's already working too hard. A team led by Dr. Maria Corina Serban at the University of Alabama at Birmingham, publishing in the Journal of the American Heart Association in July 2016, pooled the results of 7 randomized controlled trials covering 587 patients. What they found was a statistically significant reduction in systolic blood pressure, the top number I's, of just over 3 millimeters of mercury, and diastolic I's, the bottom number I, of just under 3. That's a real effect. Small, but documented. And the source wasn't garlic or beets or a juice cleanse. It was quercetin, a compound concentrated in the outer layers of red onions. So here is the answer, plainly, before anything else. The compound is quercetin. You eat it, specifically in red onion skin, and the layers just beneath it. In confirmed hypertensives, trial data shows it lowers systolic pressure by roughly 3 millimeters on average across studies lasting 6 weeks or more. That is the real finding. Now, the other technique in the title, placing onion slices on the soles of your feet. No pharmacokinetic pathway exists for quercetin to cross intact foot skin in any meaningful amount. The skin's job is to keep things out. That technique has no scientific mechanism and no human trial data. It can be set down. What matters is the part that does have evidence, and more importantly, why that evidence connects to something your kidney is dealing with right now. Here's the part nobody explains. You are probably in one of 2 situations. Either your blood pressure has been called a little high, your doctor is watching it, and you're not sure what that actually means for your kidneys, or you're already on a blood pressure medication and you're wondering whether what you eat still matters. You're in one of those 2 right now. And the answer to both of them runs through a mechanism that standard cardiology visits almost never explain, because it's a nephrology story, not a cardiology one. By the end of this hour, you'll know exactly what quercetin does inside a kidney filter, the actual step-by-step mechanism, not a summary. You'll know the one question that separates whether your blood pressure reading is being watched or actively being used to protect your kidney function. And you'll have the exact sentence that gets that conversation into your chart so it travels with you to every appointment you ever have. If you have your last blood pressure reading, even a rough number, picture it now. You're going to need it. You know the moment. A clinic off Route 41, maybe near Naples, maybe up in Ocala, doesn't matter. The printout lands on the desk. The doctor's eyes go to the number, then back to the screen. He says, "Your pressure's a little high, but we'll keep an eye on it." He's already reaching for the door, and you're thinking, keep an eye on it? That's the whole plan? But you don't say it. You don't have the words yet. So you drive home. And that night, you find a video that tells you onions work in minutes. So you try it, all of it, the juice, the feet, and you're not entirely sure it's working, but you keep doing it because the alternative is going back to that appointment and not knowing what to ask. By the end of this hour, you will have the words. If this is the kind of content you've been looking for, research explained in plain language, with a specific question at the end you can actually bring to your doctor. Subscribe. There's more where this came from, and the next video in this series picks up exactly where this one leaves off. Which of those 2 situations you're in right now shapes what you take from this. 3 types of people are watching. The first has a blood pressure reading that came back elevated recently or months ago and has been told to monitor it and reduce sodium. They've done some of that. They're not sure it's enough. They feel fine. And feel fine is doing a lot of work right now because stage 3 kidney disease is specifically the stage where feeling fine tells you almost nothing about what the filter is doing. Segment 2 is for this person. The second has been managing blood pressure with medication for a year or more. Numbers are closer to target. They've been told their kidneys are stable, but they've never had anyone explain the connection between the number on the cuff and the pressure inside the filter itself, as 2 separate things that don't always move together. Segment 3 is for this person. The third is doing everything right. Diet is clean. Medications are consistent. Their kidney filtering score is holding. They came here because they heard something about onions and they want to know whether the claim is real or marketing. For this person, the claim is partially real, the mechanism is genuinely interesting, and what you do with it next is more specific than any video you've seen so far. Segment 4 is for this person. No matter which of the three you are, the mechanism underneath is the same. And it starts with what quercetin is actually doing inside your blood vessel walls. And then, one step further, what that has to do with your kidney filter specifically. The food is red onion. More precisely, it is a compound called quercetin, spelled quercetin, and it is concentrated in the outermost dry skin layer and the 2 or 3 layers just beneath it. You will not find meaningful amounts in the white interior of a standard yellow or white onion. This distinction matters because the original video this topic is based on tells you to slice the whole onion thinly, soak it in water, and drink the liquid. Some of the quercetin from the outer layers does leach into water. That part has a real basis. The foot technique does not, and that needs to be said clearly before anything else because there is a genuine mechanism here worth understanding, and it is not served by attaching it to a practice with no pharmacokinetic reality. Quercetin is a flavonoid, a category of plant compounds that act primarily as antioxidants and as mild modulators of blood vessel function. The word antioxidant gets used loosely in a lot of health content, so it is worth being specific here. In the vascular context, which is the context relevant to blood pressure, antioxidant activity means reducing oxidative stress at the inner lining of the blood vessel wall. That lining, called the endothelium, is where the signal for vessel relaxation originates. When oxidative stress is elevated, as it typically is in chronic hypertension, that signaling is impaired. Quercetin's antioxidant activity is relevant because it targets this specific pathway, not because it is a general-purpose health compound. It is found in other foods: apples, capers, kale, tea. But red onion is one of the richest concentrated dietary sources, particularly in the outer layers, and it is available in every grocery store at a price that makes it accessible to anyone. The question the research asked was straightforward. Can regular consumption of quercetin from onion extract measurably lower blood pressure in people who actually have elevated readings? The Serban team at the University of Alabama at Birmingham answered that in July 2016, pooling 7 randomized controlled trials in the Journal of the American Heart Association. The trials covered 587 patients. The result? Systolic blood pressure, down 3.04 millimeters of mercury on average, diastolic down 2.63. Both reductions were statistically significant, meaning the probability that this result occurred by chance alone was below the 5% threshold that clinical research uses as its standard. The effect was not uniform across every subgroup. It was most consistent in participants with confirmed hypertension, meaning an established elevated reading, rather than those who were borderline or pre-hypertensive. That is an important boundary. This is not a compound that dramatically rewires blood pressure in someone whose numbers are already well controlled. It is a compound that, in people with real hypertension, appears to move the number in the right direction. Modestly, and with 6 to 8 weeks of consistent intake, not in minutes. The minutes claim in the title of the video you may have seen does not map to any mechanism in the literature. Quercetin's vascular effects accumulate over weeks. Blood pressure may drop acutely if you are anxious and then relax. That is the parasympathetic nervous system doing its job, but that is not the compound working. Setting this straight protects you from a false sense of security, and it protects the real finding from being buried under expectations it cannot meet. A treatment that works over weeks but is expected to work in minutes will be abandoned in minutes. A separate trial from Dr. Verena Brohl and her colleagues at the University of Bonn, published in the British Journal of Nutrition in October 2015, looked at this more tightly. 70 overweight to obese participants with pre-hypertension or stage 1 hypertension were randomized to receive 162 milligrams per day of quercetin from onion skin extract powder or placebo in a 6-week crossover design with a washout period between arms. In the confirmed hypertensive subgroup, 24-hour systolic blood pressure dropped by 3.6 millimeters of mercury compared to placebo. Day readings dropped. Night readings dropped. The effect held across the full ambulatory monitoring window, not just at the clinic cuff. That is meaningful because clinic readings are notoriously variable. A 24-hour ambulatory blood pressure monitor captures the real terrain, what the blood pressure is doing during normal daily activity, during sleep, across the full biological cycle. That number moving is a more robust signal than a single clinic reading. Now, does 3 millimeters matter? Here is the honest answer, bounded properly. In isolation, 3 millimeters is not what saves a kidney. Your nephrologist is aiming for reductions of 10, 15, 20 points depending on your baseline, and medication achieves those reductions reliably in a way that quercetin does not. What quercetin represents is one dietary layer in a multi-layer strategy. It is not a replacement for a medication conversation. It is not a reason to skip or delay a medication your kidney doctor has recommended. But it does sit in the same evidence category as sodium reduction, regular exercise, and DASH-style eating patterns. Lifestyle levers with documented, if modest, measurable effects on a number that matters to the filter. The Serban team noted that the quercetin-induced reductions were comparable in magnitude to currently recommended lifestyle modifications like reducing sodium intake and increasing physical activity. That comparison is the honest frame. One dietary change adds one brick to a wall that is built from many bricks. The medication is the foundation. Every brick that goes on top extends the wall. For kidney disease specifically, stage 3, which is where most of the people watching this are, the blood pressure connection runs through a mechanism your cardiology visit is not set up to explain. Your cardiologist sees a number on a cuff and is protecting your heart and your arteries, the large vessel system. Your nephrologist, when you have one, sees that same number and is thinking about what it is doing inside the filter itself. The microvessel system. Those are not the same question. The large vessel risk and the glomerular risk share a number, but the downstream consequences run through different anatomy at different pressures over different timescales. And if you do not have a nephrologist and you are managing this with a primary care provider, the filter question may never come up at all. The appointment ends with the cardiac frame intact and the renal frame never opened. One note before moving on. Onions are a moderate potassium food, roughly 150 milligrams of potassium per 100 grams of raw onion. That is not in the high potassium category that stage 3 viewers with normal potassium labs generally need to avoid. For most stage 3 viewers with a normal potassium level on their most recent labs, moderate onion consumption does not require restriction. If you are at stage 4 or beyond, if your most recent potassium lab was above the normal range, or if you are on an ACE inhibitor, an ARB, finerenone, or a potassium-sparing medication, your potassium tolerance is narrower. And the potassium in moderate potassium foods adds up across a full day of eating in ways that can matter at those stages. Bring this to your kidney team before making any dietary change based on this video. The exact threshold for you depends on your stage and your labs, and no video can substitute for that conversation. This is not a prescription. Your specific limits for potassium and every other controlled nutrient depend on your most recent numbers and your kidney team's guidance. That line is not a disclaimer added at the end. It is the single most practically important sentence in this segment for the viewers who need it most. The question in your head right now is probably, how does blood pressure get inside the kidney filter? And why does a 3 millimeter drop matter in that context when the overall treatment target is so much larger? The answer is more specific than anything your last appointment covered. And once you understand the mechanism, the word modest is going to look very different. The single mechanism is glomerular pressure. And to understand it, you need to picture what a kidney filter actually is. Your kidney contains roughly 1 million tiny filtering units. Each one is called a glomerulus, a small knot of capillaries like a miniature ball of hair-thin blood vessels wrapped inside a cup-shaped capsule. Blood flows in under pressure, gets filtered, water, waste, and small molecules pass through. Protein and red blood cells stay back, and the filtered fluid continues into the tubule, where your body reclaims what it needs and sends the rest to the bladder as urine. That is the basic machine. 1 million of them in each kidney, filtering roughly 180 liters of blood fluid every single day, every day you are alive. Here is what happens when you have stage 3 chronic kidney disease. Some number of those filtering units, maybe 40%, maybe more, are already scarred and non-functional. They stopped working at some point, maybe from diabetes, maybe from high blood pressure over years, maybe from another cause entirely. The remaining ones are doing the work of the whole kidney, and they adapt. They do not slow down, they speed up, they filter harder, run at higher internal pressure, try to cover the gap. This is called hyperfiltration, the surviving filters running beyond their normal operating load to compensate for the ones that are gone. In the short term, hyperfiltration keeps your numbers from falling off a cliff. Your creatinine stays in a range that looks managed. Your kidney filtering score holds. Everything appears stable from the outside. In the longer term, running any machine beyond its design pressure wears it out faster than it was built to wear. The filters covering the extra load are aging at an accelerated pace, even when the numbers say stable, even when you feel fine, even when the last appointment ended without any alarm. Think of it this way. Imagine a work crew that starts with 10 people, 3 of them go out sick, not temporarily, permanently. The 7 who remain do not divide the workload by 7/10 and take the rest of the day off. They cover the full job. Double shifts, weekends, they are burning through their reserves to keep the numbers looking normal. That is your kidney filter right now. The survivors are carrying the full load on behalf of the ones that are gone. Now add blood pressure. Specifically, high blood pressure does not just stress your arteries, it transmits, partially, depending on how well the incoming vessel to the filter can regulate, into the filter itself. The afferent arteriole, which is the small vessel feeding blood into each glomerular ball, tries to buffer that incoming pressure before it reaches the filter. It is designed to auto-regulate, to absorb pressure changes and deliver blood to the glomerulus at a more constant, lower pressure than the systemic circulation. When it fails, which it does more readily in chronic kidney disease and more readily with age because the vessel wall itself has changed, the elevated systemic pressure lands directly inside the filter and becomes elevated glomerular pressure. The filter is already running hard from hyperfiltration. Now it is running hard with the external dial turned up. Sustained glomerular hypertension, elevated pressure inside the filter, damages the filter membrane progressively over time. It stretches the tiny capillary walls beyond their tolerance. It forces protein through openings in the filter that protein should not be passing through. That protein leak is not just a warning sign, it actively injures the downstream tubule cells as it passes, triggering a local inflammatory response that creates scarring, which takes more filters offline, which pushes more pressure onto the ones remaining. The cycle is self-reinforcing. Each step makes the next step worse. Each lost filter means the remaining ones run harder. Running harder means more pressure. More pressure means more damage. This is not a slow linear decline, it is a self-accelerating one. This is why blood pressure and chronic kidney disease are not parallel problems that happen to coexist. Blood pressure is a direct dial on the progression speed of the kidney disease itself. Every point you knock off the top number of your blood pressure reading is easing the pressure on the filter directly, not metaphorically. Through a real fluid mechanics pathway, systemic pressure, transmitted through the arteriole, landing in the glomerular capillaries. A 3 millimeter reduction is a 3 millimeter reduction in the force that is transmitted into filters already running at an unsustainable pace. You stack that reduction with sodium restriction, with medication, with exercise, with weight management, and each layer of reduction compounds. The crew doesn't get a day off, but the pace gets dialed back, and that makes a real difference over 5 years. Where does quercetin fit into this? Quercetin acts on the endothelium, the inner lining of blood vessel walls. Healthy endothelial cells produce nitric oxide, a small molecule that diffuses into the surrounding smooth muscle and signals it to relax. When the smooth muscle relaxes, the vessel widens slightly, resistance drops, and blood pressure falls. In conditions like sustained hypertension, endothelial function is impaired. The cells produce less nitric oxide, partly because oxidative stress at the vessel wall damages the enzyme responsible for making it. Quercetin is an antioxidant that appears to reduce that oxidative stress, partially restoring the nitric oxide signal and allowing the vessel wall to relax more normally. The vessel relaxes, resistance drops slightly, blood pressure comes down by a few millimeters, and the transmitted pressure into the glomerulus drops with it. The Brohl team at the University of Bonn noted that the exact mechanism behind the blood pressure reduction they observed in their trial remained incompletely defined. The expected biomarkers of endothelial function, including specific adhesion molecules and enzyme activity markers, did not show significant changes despite the blood pressure effect. That is an honest finding, and it needs to be stated plainly. We know quercetin moves the number. We have reasonable mechanistic hypotheses about why. The exact pathway in humans is not fully confirmed at the level of specific biomarkers. The effect is real. The mechanism is biologically plausible and coherent. The precise chain of events has not been pinned down in human trials to the satisfaction of the research community. Apply that boundary before making any decision based on it. What is confirmed? Any lever that reduces systemic blood pressure reduces the pressure transmitted into the glomerulus. The 3 mm reduction from quercetin is not clinically dramatic on its own, but stacked with sodium reduction, with appropriate medication, with exercise, with other verified lifestyle levers, it is a real brick in a wall that protects the filter. The crew working double shifts does not need one sweeping change. It needs every tool that eases the pace, one shift at a time, compounding over months and years without asking the remaining filters to carry more than they already are. Here is the thing almost every blood pressure video skips. Your cardiologist's job is to get a number below a threshold for cardiac and stroke risk. Your nephrologist's job, and yours, Das, is to keep that number low enough for long enough that the glomerular pressure inside the surviving filters stays in a range where they can last for the years ahead of you. Those two goals sometimes point to the same number, but the reason behind the target is different. The stakes attached to each point of reduction are different. And the only way you bring the right reason into the room is if you know it before you walk in. Sit back for a moment. Picture your most recent blood pressure reading. The number is on the printout somewhere. Now ask yourself, has anyone ever explained to you what that number is doing specifically inside the filter, not in your arteries, not to your heart, but to the glomerulus that is still working? If the answer is no, you are not behind. You are exactly where this video found you. And the next segment explains why that conversation has not happened yet and what you do about it. If that mechanism just landed for you, the connection between blood pressure, glomerular pressure, and the crew that's still doing its job, hit the like button. It helps this channel reach people who are asking the same questions you just asked. And leave a comment below, what number on your last kidney panel are you most confused about? Those comments shape what comes next. You have probably asked it already. If quercetin has real trial data behind it, if the blood pressure connection to glomerular pressure is a known mechanism in nephrology, why hasn't your kidney doctor brought this up? The answer is not what the internet usually tells you. It is not suppression. It is not indifference. It is a structural timing problem, and once you understand it, the frustration points somewhere more useful than a person. Your nephrologist's average appointment with an established chronic kidney disease patient runs 12 to 20 minutes. In that window, they are reviewing your labs, kidney filtering score trend, creatinine, potassium, bicarbonate, urine albumin test if it was ordered, reconciling your medications, addressing any new symptoms, checking blood pressure, adjusting referrals, and managing any complications that have emerged since the last visit. That is the minimum viable visit for a stage 3 patient with multiple comorbidities, which most stage 3 patients are. There is no protected time in that structure for a conversation about quercetin dosing from red onion skin. Even when the doctor knows the literature, even when they find it interesting, the visit is not long enough to get to it when medications, labs, and symptoms are ahead of it in the queue. The other part of the timing problem is the distance between when research is published and when it enters clinical practice guidelines. The Serban meta-analysis was published in 2016, the Brohl trial in 2015. the KDIGO 2021 Guideline for Blood Pressure Management in Chronic Kidney Disease. The most authoritative clinical document on this topic, the one that shapes what nephrologists do in practice, covers lifestyle interventions in a broad category that includes diet, sodium, weight, and exercise. It does not name quercetin. It does not name dietary flavonoids specifically. The research predates the guideline update, but the research has not made the jump from literature to protocol. That gap runs 10 to 17 years on average for evidence to reach routine clinical practice, a figure documented across multiple studies of knowledge translation in medicine. The 2016 paper exists. The 2021 guideline was written in the years before it, and the next update has not yet arrived. The cycle is slow by design. Guidelines require a level of consensus and systematic review that individual studies, even good ones, do not automatically trigger. What this means practically, your nephrologist may know this literature, or may not have encountered it in a specialty that covers an enormous range of topics from dialysis to transplant to rare glomerular diseases, or may have seen it but have no structured way to introduce it in a 15-minute visit already packed with more acute priorities. None of those scenarios makes them negligent. All of them make you the person with the most direct access to this information at this moment, the person who spent an hour with a video that went through the research, and the most direct incentive to bring it in. There is one more layer here. Blood pressure management in chronic kidney disease sits at the intersection of nephrology, cardiology, and primary care. Your blood pressure may be owned by your primary care provider if you do not have an active nephrologist referral, which most stage 3 patients in the early years of managed disease do not. Your cardiologist, if you have one, is managing blood pressure primarily for cardiac and stroke outcomes. The kidney lens: what is this number doing to my glomerular filter specifically, and what is the kidney-specific target? May not be anyone's explicit job in your current care team. It becomes yours, not because the system failed you, because the system was not designed for that level of integration across specialties for a stage 3 patient who still feels fine and whose numbers are close to target. The pattern your nephrologist is running is not wrong. It is pattern efficient. Medications first because the effect size is large and the evidence is definitive. Lifestyle as a broad category because the guidance is well established. Dietary specifics as an add-on conversation if time and the visit structure allow. Quercetin sits in the dietary specifics bucket. The bucket almost never opens at a standard chronic kidney disease visit. The appointment ends before it gets there. That is the structural truth, stated plainly. The nephrologist is not at fault. The system is named. The only way the pattern updates for you specifically, before the guidelines catch up, before the 12-minute appointment expands, before the specialty integration that would connect your nephrologist and your cardiologist and your primary care provider in a single conversation, is if someone brings the new information into the room. That someone is you. And the next segment gives you exactly what you need to do it. This is about one conversation with one specific purpose: getting blood pressure tracked as a kidney protection lever, not just a cardiac target, and getting quercetin's role in your diet documented so it becomes part of your longitudinal kidney record. Here are the specific things to ask about. 4 items. Each one is different in nature, and you do not need to raise all 4 in a single appointment. 1 per visit, introduced naturally, is enough to move things forward without the encounter feeling rehearsed. The first is your blood pressure trend, not your blood pressure reading. A single reading in a clinic is taken under specific conditions, often after a wait, sometimes anxious, sometimes after coffee, always under fluorescent lighting in a room that produces mild white coat effect in most patients. What protects your kidney filter is not one number on one day. It is the direction of your numbers over time. You can ask, has my systolic pressure been trending in a consistent direction over the last few visits, or is it stable? If your chart shows 3 readings in the same range over a year, that is useful information and likely a real reflection of where you are. If it shows a slow upward drift of 3 to 5 points per visit, that is a different conversation. One about whether the current strategy is holding and what the options are if it is not. You cannot have that conversation if you only ever know today's number without context. The second is the glomerular pressure question itself. You do not need to use that term. It is clinical language, and it may read as rehearsed. You can ask it this way: Is my current blood pressure target set based on my kidney function specifically or based on cardiovascular risk? The 2021 KDIGO guideline recommends a systolic target below 120 millimeters of mercury for adults with chronic kidney disease not on dialysis, a target many patients have not been told explicitly because it is lower than the standard hypertension target and requires a specific clinical justification to pursue aggressively. Your blood pressure may be controlled by cardiovascular standards at 135 and still be above the kidney-specific target. The question opens that distinction without challenging the provider, without implying they are wrong, and without requiring you to cite a guideline number. It is a genuine inquiry about what goal the management is aimed at. Most doctors will answer it directly and either confirm that the kidney-specific target is what they're aiming for or acknowledge that the conversation is worth having. The third is the quercetin conversation specifically. You are not asking for a prescription. You are not asking your doctor to endorse a supplement. You are asking whether adding red onion, particularly the outer layer portions that concentrate quercetin agis, is appropriate for your stage and your current medication list. The potassium interaction matters here for some viewers. If you are on an ACE inhibitor, ARB, or potassium-sparing medication, your doctor needs to know about any dietary change, even a modest one. The conversation is this: I read that quercetin from red onion has documented blood pressure effects in randomized trials. Is there any reason I should not add more red onion to my diet at my current stage and with my current medications? That question does three things. It signals that you are bringing evidence, not anecdote. It routes the decision through the clinical team where it belongs. And it invites the doctor into a conversation rather than demanding a position or bypassing their judgment entirely. The fourth is the documentation request. This is the keystone tool. Whatever decision the two of you reach, whether the doctor is enthusiastic, cautious, or neutral about the dietary angle, you want it on your chart. The reason is straightforward. A chart note travels. If you switch providers, see a different nephrologist, move to a different city, or end up in a hospital or urgent care setting in the future, the note is there. It does not require you to re-explain everything from the beginning. It does not require the new provider to take your word for what was discussed at a prior visit. The record is the continuity. The sentence is this: would you be comfortable noting in my chart that I've been adding red onion regularly to my diet and that we discussed blood pressure as a kidney protection lever so we can track whether my pressure trend is moving in the right direction at my next visit? That sentence does something simple and permanent. It creates a documented baseline. It makes the conversation part of your longitudinal record. It signals to every future provider who reads that chart that this patient is engaged, tracking, and has a strategy. Patient is incorporating dietary, quercetin, and tracking blood pressure as a kidney protection strategy. That note changes the next conversation automatically, without you having to start from scratch. 3 possible responses when you ask this. First, the doctor engages, asks about your intake, confirms the potassium safety check for your specific stage and medication list, and notes it. This is the best outcome. You leave with a documented strategy and a provider who is aligned with the direction. Second, the doctor is neutral, says something like, "That's fine, no concerns at your stage," and does not write it down. In this case, you follow up directly. Would you mind putting that in the chart note anyway, just so it's part of my longitudinal kidney record? Most providers will accommodate this without hesitation. It is a small request, and it signals organized, engaged patient behavior that most clinicians respond to positively. Third, the doctor dismisses it, tells you the effect is too small to matter, or that diet is not a significant factor at your current stage, or that they are not familiar with the research. In that case, you do not argue. You do not get angry. You do not threaten to switch providers. You say, understood. I just wanted to make sure I was connecting the dots between what I eat and what's happening to my kidney numbers. I will keep tracking it on my end." You leave. You track it anyway. And at the next visit, you bring the data as an update, not a challenge. Do not bring a printed research paper to the appointment. It reads as confrontational in most clinical settings, regardless of intent. The question is enough. The chart request is the instrument. The data you bring to the next visit is the follow-through. These three tools, deployed in the right order at the right pace, across more than one visit if needed, accomplish what no single confrontational moment could. The doctor can only protect a result they know is yours to protect. If it is not on your chart, it does not travel with you. If it is, it does to every setting, every provider, every transition in your care that lies ahead. If the chart documentation sentence is something you've never heard before and you're going to use it, give this video a like. That is the signal that this kind of specific, usable content is what you came for. And comment below, have you ever asked your doctor to document something in your chart? Tell me what happened. Those comments help other viewers know they are not the only ones navigating this conversation. If your blood pressure is being managed and you want to understand all the levers that protect your kidney numbers long-term, there is a full playlist built around exactly that. It is called Kidney Health Essentials. It covers the tests to ask for, the numbers to track, and the conversations that matter. One mechanism per video. The link is in the description. And if you are not subscribed yet, now is the time. The next video in this series goes deeper into a marker that changes before your blood pressure does. Sit back for a moment. Picture this. 6 months from now, you are in that same exam room. The printout lands on the desk, but this time you have 3 things the person in that chair 6 months ago did not have. You have your last 3 blood pressure readings written down with the dates next to each one. You have a chart note from your last visit that says you've been eating red onion consistently and that you and your doctor discussed blood pressure as a kidney protection lever. And you have a question ready before the doctor says a word. Has my systolic trend moved since we documented this? The doctor looks at the chart, looks at you, and something shifts. Because you are not a passive receiver of information anymore. You are a person who connected a specific dietary compound to a specific physiological mechanism to a specific number that is tracked, documented, and compared over time. You brought continuity into a system that is not designed to create it. The chart note you asked for at the last appointment is now the opening line of this one. The doctor is reading a record of an ongoing strategy not starting from zero. That is not a different food. That is a different identity. The second picture. 3 months from now, someone in your life, an adult child, a sibling, a friend from your neighborhood in Tampa or Sarasota or Fort Myers, gets a blood pressure reading that comes back elevated. They are scared. They do not know what questions to ask. The appointment is 2 weeks away, and they are spending the time between now and then searching the internet for anything that sounds reassuring. You sit down with them, and you tell them, blood pressure is not just a heart number. At a certain point, and especially once kidney function is part of the picture, it is a kidney number too. The filter inside each kidney is sensitive to that pressure in a way that most doctors only discuss when things have already progressed further than they need to. And there is a very specific question to ask at the next appointment that most people never think to bring in. You have the question, you know the mechanism, you know the study, you know the chart documentation request, and you are the person who brought that into the room, not because you went to medical school, but because you spent an hour watching a video that took the research seriously and handed the tools over without hiding them behind a program. That is the skill this video is handing over. Not a food recommendation. A way of understanding what a number means and in what to do about it, that works for every number on your kidney panel. The blood pressure finding is one example. The principle is portable. Kidney filtering, score slope, creatinine trend, urine albumin reading. Each one has a mechanism, a research anchor, and a specific question that connects it to your chart and to the conversation you need to have. You now have the template for all of them. The identity is not person who eats red onion. The identity is person who reads a lab result and knows what lever it connects to. The 5 questions people search for most on this topic. Does eating onion actually lower blood pressure, or is that just a myth? The evidence sits in the middle of those 2 options. A 2016 meta-analysis in the Journal of the American Heart Association pooled 7 randomized controlled trials and found that quercetin, concentrated in red onion's outer layers, reduced systolic blood pressure by an average of just over 3 millimeters of mercury in people with confirmed hypertension. That is a real, statistically significant effect, and a modest one. It belongs in the category of documented lifestyle levers, comparable in effect size to sodium reduction, not in the category of clinical treatment. If your blood pressure is significantly elevated, dietary quercetin is a layer in a strategy, not a replacement for a medical conversation. If someone tells you it is a myth, they have not read the trials. If someone tells you it is a cure, they have not read the bounds. Can you lower blood pressure in minutes at home? The short answer is no, not through quercetin or any dietary compound. Blood pressure can drop acutely when you are calm, rested, and breathing slowly. That is the nervous system regulating itself, not a food compound doing anything. Quercetin's vascular effects accumulate over 6 to 8 weeks of consistent intake based on the trial data that exists. The minutes framing in many videos conflates two separate things: the relaxation response, which is real and immediate but not compound-driven, and dietary blood pressure modification, which is real and slow and requires consistency over weeks. Knowing which is which protects you from false reassurance and from abandoning a strategy that actually works because it did not show up on Tuesday. Is onion safe for kidney disease? For most stage 3 chronic kidney disease viewers with normal potassium levels on their most recent labs, moderate onion consumption does not require restriction. Onion is a moderate potassium food, roughly 150 milligrams per 100 grams. That is not in the high-risk category for early-stage kidney disease. The stage safety caveat matters at stage 4 and beyond, or if your most recent potassium lab was above the normal range, or if you are on an ACE inhibitor, ARB, finerenone, or a potassium-sparing diuretic, all of which narrow your potassium tolerance and make even moderate potassium foods worth monitoring across a full day. This is not a prescription. Your exact limits depend on your stage and your latest labs. Bring any dietary change to your kidney team before you make it. What is quercetin, and how do I get it from onion? Quercetin is a flavonoid, a plant compound that acts as an antioxidant and mild modulator of blood vessel wall function. In onions, it concentrates heavily in the outermost dry skin layer and the 2 or 3 layers immediately beneath it. The pale white interior of a white or yellow onion has very little. Red onion has more throughout, including in the layered flesh, making it the better dietary source by a meaningful margin. Cooking reduces quercetin content, roasting more than sautéing, frying more than either. Lightly sautéed or raw red onion preserves the most. Soaking thin-sliced red onion in water, as the original recipe suggests, does allow some quercetin to leach into the liquid. That part has a real basis and is a practical way to consume it if the flavor of raw onion is not tolerable. Eating the food regularly, in whatever form is sustainable, is the practical delivery method. Why are you telling me this? What's your angle? The honest answer: this channel explains what the research says, what it does not say, and what specific question you can bring to your kidney doctor as a result. No supplements are being sold here. No program is being promoted. The quercetin finding is real and bounded. Real because the trial data is there across multiple studies. Bounded because 3 millimeters is not a cure. And the foot technique has no scientific mechanism supporting it. The goal is one better appointment, not a new product in your cabinet. If anything in this video led you to a conversation with your kidney doctor that got documented in your chart, this video did its job. Here is the broader pattern this finding sits inside. Blood pressure is one of 3 main progression drivers in chronic kidney disease, alongside proteinuria and the protein load on the remaining filters. All 3 connect to the same underlying mechanism: how much pressure and work the surviving kidney filter is handling in any given 24-hour period. Every lifestyle lever that meaningfully reduces blood pressure, sodium reduction, weight management, consistent exercise, dietary compounds like quercetin, operates through the same downstream pathway. It eases the pressure transmitted into the glomerulus. It does not stop chronic kidney disease. It does not reverse scarring that has already occurred. It affects the rate at which the remaining filters wear out, the pace of the decline, not the existence of it. The quercetin finding is one brick. Sodium reduction is another. Medication is the foundation. None of these is the whole answer. All of them matter in the same direction. The skill this video is transferring is not about onions specifically. It is about recognizing that every number on your kidney panel connects to a mechanism, and every mechanism has at least one lever you can name, track, and bring into an appointment. That skill works for your blood pressure, your urine albumin reading, your creatinine slope, and every other number your doctor reads off that printout in 4 seconds. No new tests, no new interventions, the same appointments you already have, entered with different questions. The number on that printout was never just about your heart. It was always about the crew you have left. That crew, the filtering unit still doing their job, running double shifts, covering for the ones that are gone, responds to every choice you make about what you eat, how you manage your stress, which questions you bring into the exam room, not dramatically, not overnight, but consistently, across months and years, the direction you push those levers is the direction your kidney function moves. Write down your last blood pressure reading. Next to it, write down the date it was taken. That is your baseline. At your next appointment, you now have the question that connects it to the filter, not just the heart. Bring it in. If you are not subscribed yet, now is the time. This channel covers one number, one mechanism, and one conversation per video. And the next one goes deeper into a marker that can change before your blood pressure does. Subscribe so you do not miss it. And share this with the one person in your life who is also managing a kidney diagnosis or an elevated blood pressure reading and does not know about the filter connection. Not as advice, as information. The kind that makes one appointment better. The next video in this series looks at another number on your panel, one that changes before your blood pressure does and before your creatinine does, and that most kidney panels still do not routinely include. If that feels like the conversation you have been waiting to have, it is already waiting for you. You have the words now.